Starting. All attendees are in listen-only mode.
Well, good evening. Hey, Rich, how you doing?
Hey, Gay. I'm doing fantastic. You sound a little scratchy. You've been talking for a few days, haven't you?
Yeah, I was going on like a 3-week trip talking every day, so my voice is a little bit raspy, but we're good to go. I'm excited about this webinar tonight, Treatment Steps for Dental Sleep Medicine Patient Flow. This is, I really think, kind of the backbone of what dentists need to know to do dental sleep in their practices, because we're comfortable with a lot of the technical parts, but what do we do after we take impressions? What do we do for follow-up? And I think talking about that today will be really worthwhile for the dentists who are just getting started, and even if you're doing it, a lot of this, I'll give you some pointers on how to make these appointments really efficient.
Absolutely. And you know, we hear dentists ask us all the time, don't we, Guy? You know, where do our patients come from? And you know, realistically, you know, 1 in 5 of every adult patient who's walking through your doors every day has sleep apnea and doesn't know it. So, you know, there's just an abundance of patients out there. For those of you who are getting into this, you're getting into it at a good time. The reimbursement is getting easier. You know, everything's getting easier. And, you know, we're going to go tonight. We want to kind of get your arms wrapped around, you know, the steps that we go from A to B to C.
Yeah, 1 in 5 adults, so let's just emphasize that. There's 20% of the adults have this problem. And in my opinion, it's the most significant undiagnosed, untreated medical disorder in our country. And, you know, I know we're involved in this, and so you see what you want to see, but I've been polling the dentists I've been talking to say, in the last 5 years, have you seen a big increase in sleep in the media? And everybody's like, absolutely. I mean, it's something that used to be, even 5 or 6 years ago, oh, we didn't talk about sleep, or if we did, well, you don't need sleep, and you know, there's something wrong with you. You know, you need to sacrifice the sleep to succeed. And now we've known this, but now it's in the media more that sleep's important, and we're realizing how much it affects our health. I mean, you can look at all the just a quick Google search of people that are interested in this. Ariana Huffington, Dr. Oz. It's on the cover of National Geographic. I mean, so sleep is important. It's one of the fundamental things to keep our bodies functioning adequately and to live better and to live longer. And I think when we get involved in this, Rich, one of the things people come to me and go, well, you know, what's involved in dental sleep? Is this, you know, is it difficult? I mean, you look at this. I mean, crowning teeth, doing dentures, implants, that's difficult. I mean, if you can learn to do that type thing, you can do dental sleep, because dental sleep's not, I don't think anything, one particular thing is difficult. Would you agree, Rich? It's complex. There's a lot of parts, but as far as the complexity of each of these steps, they're all pretty simple when we go through them, I would say.
It's just new, Guy. You know, it's something that we didn't learn in school. It's something we don't feel comfortable with. And I think what we hope tonight will do is answer a lot of those questions that you have, just like Guy said. Well, I did this. What do I do next? Or the patient, you know, is this. What do we do next? So that's what we want to kind of talk about. And I guarantee you, if you can learn how to do an implant, you can learn how to do dental sleep devices. You know, but I do like to say, Guy, don't dabble. Right. You know, if you're going to do it, learn how to do it and do it well. And as dentists, you know, we're in a perfect position to do this. You know, most people in the United States go to see the dentist at least once a year or every couple of years to get their teeth cleaned and checked up. Right. They don't usually go see the doctor unless something's hurting. Now, sure, we all have patients like that as dentists. The only time they come in is when a tooth's blown up or something like that. But, you know, we're in a perfect position as dentists to start looking at the airway and start doing something about it. And as you recall, Guy, the American Dental Association says we should be screening our patients. That's been out for a while now.
You know, a year and a half ago, ADA's position is that we're in the best position to screen the patient. So we're going to try to put these moving parts together. Again, it's not any one difficult part in and of themselves, but when you string them all together, sometimes people don't have a system for each of these steps. And then if you have a system that's broken anywhere along the way, like a chain here, you're going to see that maybe you don't succeed to the extent that you'd like to. We're going to go through the processes, system, and how we as an organization can help support you on your journey through getting sleep involved in your practices. That's what we specialize in. That's what Rich and I have spent the last 15 years or so doing, is putting together systems to help you. I think, Rich, you came up with this analogy or this demonstration, and it's still very, very true for what has been going on in the last 40 years in the medical world.
Yeah, so, if you're at your doctor, I did a lunch and learn today, Guy, and the PA, got to talk to the PA today, and she said, I'm just not picking up on this. When my patients say they're sleepy and they're tired, and I think, man, we need to give them a med because they're not sleeping well. They have insomnia. I'm not picking up on the fact that this is sleep disordered breathing. And of course, in the medical model, when we suspect that they have a problem, we talk about getting a sleep test. A lot of people won't go because they don't want to go to a sleep lab. They've heard horror stories about it. So, how many people will go when we do that? Maybe some people are better at it than 5 out of 10, but we think most, people, that's about how many go. And then how many do we confirm a diagnosis in those? The majority of those are going to have sleep apnea. And if we only give them one treatment option, which is CPAP, how many will go get it, and how many will wear it? At the end of the day, we're just not doing a very good job of treating these people. The medical model has simply failed. You can't sugarcoat it any more than that, can you?
No, and these are numbers, our assessments. Put in your own numbers. It's not going to be anywhere near 10 when you look at where we are, because 85% of the people that have this don't know they have it. So that's one of the problems that we want you as dentists to work on. Imagine now that we have our dentists. More dentists spend time with their patients than the physicians. So we're going to have more at bats, more time to talk to these patients if we follow the American Dental Association's recommendation and start screening these people. So the funnel in the top is going to be greater because we're seeing more patients. It's our job to do this. And if we can send them home with something about the size of your iPhone or something that you strap on your hand, there's different home sleep testing models. How many of those patients can we take from our office and get them on the road to being tested if all they've got to do is wear something we provide or order or work with their physician to get to them at the end of the day? We think it's 9, maybe even 10, because Rich and I are believing this, and we've had patients who maybe didn't make it that probably should have had someone gotten them tested sooner. So our passion is there to get this done. How many will actually have apnea? Well, if we do a good job of screening these patients, they will. How many will pick up the device and wear it? Well, the vast majority of them will wear it. We know that from our clinical experience of doing thousands of these devices that Rich and I and our practices have done over the years. How many will wear it most every night, all night long? I estimate 7 out of that 10. Call it 6, call it 5. You're still 2-3 times greater, a greater improvement over what the status quo has been for 40 years. So this needs changing. That's why we're here. We will help you with the steps that you need to do to change this. You all have to get out there and screen your patients, start testing them, getting them treated, and go through these steps. So one of the things that we'll talk about next time is, once we get these steps in place, we would like you to go out and talk to the physicians. How many physicians you meet with this? I know at least 2 of them that I talked to you on the way to and from there this week.
What's today? Tuesday? So I did lunch yesterday and a breakfast and lunch today. So 3 so far, in 2 days. So that's my passion, Guy. I can't wait to talk about that. And, we have a lot of experience in that. And I think we can give you some real tools that will really help you feel confident when you go to talk to those people, and how those things would typically go, and the things that you talk about, and the things you might bring, the questions that they're going to ask. That's going to be a good one. I'm looking forward to that one, Guy. When do we do that? Tuesday, June 11th. Okay.
Tuesday, June 11th, same time, 8 o'clock Eastern and 7 o'clock Central. So a little housekeeping. You will get CE for this. You should get it within 72 hours. So if you didn't, check your spam folder. If it's not in the spam folder, then contact us. Also, we have our whole team of dental sleep experts from DS3 on board here. They're answering your questions. If you'll type in your questions into the question box, we had several hundred people register tonight, so we can't open up the mics, but we will answer your questions. Our team will answer it. Rich and I will answer them. We'll get to all the questions before the night's over, so keep typing them in the question boxes. You know, Rich and I have met going on, what, 15, 16 years now probably, and I was dabbling, Rich was doing more of it at the time. We've strangely enough been doing this about the same amount of time, although Rich has been doing it more. But I know we were talking the other day, we've done at least thousands of devices between us, and I don't know how many that number is, but it's a lot. And what I like to tell people, which I'm certain is true, we don't know everything, but we know a heck of a lot of what not to do. So and we'll share that with you.
As we say, Guy, ask me how I know. You know,
Yeah.
You shouldn't do that because we made a lot of mistakes along the way. So, yeah, and if you get a chance to hear Guy talk or teach this, you should take him up on that. He's a great motivator, and he has a way of making this simple. That's what we want to try to do tonight. We want to try to make this as simple as we can for you, for how you go through those steps. I mean, this is who we are. We are Dental Sleep Solutions, the DS3 experience, you know, and this is what we do and how we do it. We do nothing but help dentists succeed in dental sleep medicine through these types of things.
And we're going to go through this fairly quickly. This is a half day in our course, over a half day, what we're going to go over here in the next 50 minutes. And so if you want more answers and we don't get to everything and you want just some help, just type in consultation tonight at any point, or consult for short, and one of our trainers will meet with you, answer your questions, clarify anything that you need it clarified, talk to you about how we can help you bring your practice to the next level with dental sleep. So anytime along the way, just type in consult or consultation. We do have teach courses, as Rich mentioned, all over the country. Just got finished teaching a bunch here. That's why my voice is gone. But we do 2-day courses. You get a sleep test and a dental device for $1,000. But if you attend one of these webinars and you type in tonight course, you'll save $200 on that. And that includes a team member so the doctor and the team member. And you get a dental device made by the lab, and you actually get a sleep test that Friday night that we do. And it's a really great course. Go ahead.
As I like to say, Guy, it's the cheapest way to get diagnosed and treated if you,
That's true.
if you think you have sleep apnea. So
that's true. Yes, absolutely.
If you're a dentist out there or staff and you think you might have it, it's worth going to the course just to get diagnosed and treated. So
yeah, absolutely, and you'll not be disappointed. Rich just finished the advanced course a few weeks ago in Dallas. I guess it's in Dallas again then in October.
Yeah, fantastic. You know, we limit that to about 20, 25 docs and staff, and we do a lot of hands-on stuff. We do a lot of combination therapy. We just do more advanced stuff. You know, if you've only made 2 devices, I don't think it's a good idea to take that course. But if you've made 30 or 40, 50, I don't know how many, Guy, you know, probably
Maybe
30, 40. Yeah, at least something like that. And you're to the point where you like to learn a little bit more about, you know, how to do some things and you know, fantastic. Great opportunity.
Had rave reviews. And last one here is this North American Dental Sleep Medicine Symposium. It's our 4th year coming up. We have some incredible speakers here. I mean, each year, Jason Tierney, our COO, does this meeting and does a phenomenal job. I don't know how he gets all these people to speak, but he does. You can read them yourself here. Some of the leaders in the country. It's in Clearwater Beach, February 14th, 15th. Room rates $269, which is incredible for that time of year. We will run out of rooms, so we won't run out of rooms. We'll run out of rooms for that rate. So if you want to lock that in, look at those dates. We'd love to see you there. So tonight we'll talk about the steps. And at a high level, you need a system and team members accountable for each of what we call the 4 pillars, which are screening, testing, treating, and billing. You need systems in place and team members who own those systems. Can be the same team member or different ones as we go through this. And, you know, I really enjoyed my weekend last weekend in Atlanta. We had quite a few DS3 members there, Rich, and they all left going, wow, we're spending way too much of the dentist time on this. And as they went through the systems and realized, you know, as a dentist in most states, all I have to do is be there the day they deliver the device. You know, our scanners and everything like that. I mean, you know, the dentists themselves can do very little of this if you have a really skilled team. So there's no reason why a dentist should be spending over an hour. We touted at 45 minutes, and I'm certain you can do that if you use these steps wisely and with a good system like DS3 as the backbone. This is the hardest slide to talk about in some ways, I think, Rich, because it's probably the most important, isn't it?
It is, and we could, we could talk about this, nothing but this guy for an hour, I'm sure. When we think about why we do this, I think that's important. I think you all need to sit down with your staff and have that kind of conversation. We can tell you unequivocally, without any doubt, that the people who make up their mind that they're going to make this work, make it work. They
Right.
just do. When you have that resolve and you say, hey, we're gonna make this happen. There is not a better opportunity in dentistry right now than sleep medicine. I know it sounds like an oxymoron, but it just, you're getting into this at the right time. We've been working at this for a long time, and you've just got to have your team on board too. So you got to get your team involved, and you guys need to talk about how you're going to do this, and then don't do it by yourself. There are other people that have helped pave the road. That's what we've done, and team up with somebody who can help you do this.
Yeah, until you believe that it's your job to screen these patients and get them tested and possibly
It's not going to happen.
it's not going to happen. I'll emphasize this one more time because it's the most important thing. The team has to realize that would you let a patient leave your office without perio probing? Of course not, because it's our job to perio probe them. Well, this, as the ADA says now, and our belief is, it's your job to screen these patients and get them tested if they're at high risk. And shame on the dental offices that don't, and let's hope it doesn't matter to someone dying in their sleep or falling asleep in a car wreck, which all those things have happened, to make you believe it's your job. So once you believe it's your job, the rest of this really, really becomes easier. And I think it's your why. We've gone over this in past webinars, but you have to believe this is your job. You have to believe it's an important thing to do. It's essential to our patients' health, and it's something that you're not just doing to earn extra income. You're doing it because it's something that you believe in. And when you and your team do, it becomes the rest of this that we're going to go over. All you have to do is follow the systems that we're going to give you, and you'll cruise right along, because doing this isn't hard. The believing in it is kind of on you, and the patients are everywhere. I mean, it's amazing to me, Rich, when we do these courses. We always go out to dinner on Friday night, and we always talk to people about sleep. And I found a patient for someone on the way to the course of my Uber driver. I mean, everywhere you go, if you just start, people ask you what you're doing, you tell them I'm here to help patients with sleep apnea. They have themselves, their brother, their sister, brother-in-laws. This weekend, one of my wife's friends was visiting town, and her brother needs help, so we're finding him someone. It's everywhere. You just got to start talking about it and looking for it.
Yes, you don't have to go off and buy, TV time or anything like that. The lowest hanging fruit are the patients walking through your doors every day. So can you buy TV time? Sure you can. Can you optimize your website? Yes, you can. Should you do all of that? Yes, you should. Should you have a dedicated part of your website to sleep? Absolutely, you should. There's a number of people out there who can help you do that, and you should do all of those things. But at the same time, you got to start screening your patients.
Yeah, and as you do, not the low-hanging fruit, the fruit over here in the basket. You've got patients in your own practice who aren't wearing their CPAP. That's not low-hanging. That's fruit in the basket there. Patients needing your help. If they're not wearing their CPAP every night, all night long, they're picked in the basket, ready to go. So you need a system to screen your patients. And this is something that I know Rich and I both feel passionate about. Dentists need to be doing this. No one else is doing it properly. Most people who have this problem, the vast majority of them don't know they have this problem. And so you need a system to go out and quickly say, okay, here's all the people. This one here is at high risk, and we need to talk to them about getting a sleep test. And there's a lot of ways to doing that: screening tools, marketing, letters to existing patients. I love the posters that you put up in your office. Do you snore? Are you sleepy? If you can't wear your CPAP, we have all those kind of things. But you need a system to do this. It's not just, okay, we'll just start asking people about it. And this is the way I did it.
I will say, though, Guy, if all you did for the next year was ask your patients, have you had a sleep test?
Yeah.
and they say yes, and you say, are you wearing your CPAP? And they say no,
Right.
you could probably add $50,000 to your bottom line if that's
And
all you
and
did.
and helps a bunch of people live better and live longer at the same
And
time.
if you do more of the stuff that we're going to talk about doing, you help even more people. So, there are red flags. Anytime dentists and especially hygienists, we found over the years, Guy, are so good at reviewing medical histories. Any changes in your medical history, Guy? Oh, I'm taking that blood pressure med now. My blood pressure just keeps creeping up, and now they got me on a medication. And, I even wanted me to see the cardiologist because I have AFib now. These things should be red flags, as they're going through there, and you see all of these things. I was taught, Guy, as a dentist, you wake up with a headache, well, you make them a night guard.
Yeah.
As far as I know, that's what most dental schools still teach. So, a lot of that has to do with oxygen and not oxygenating properly. So when you review the medical histories and you look at this, you should look at these. You see them all on the slide there that Guy put together. So they're all red flags, and you want to do that. Clinically, we look in their mouth and we see big tongues. We see a jaw that's set back. We see narrow arches. We see people who can't breathe through their nose, their mouth breathing. We see, worn teeth or clenching. Big necks, and we see big necks, big tongues. People open their mouth and we see scalloped tongues. All of these things should be a little light bulb going off saying, hey, we need to think about getting you a sleep test.
Absolutely. And so I think that's the way I used to do it in my practice. I printed that red flags out. We kind of developed it. I memorized it. I had my team go, but then we got busy with, a crown or broken tooth or, going behind in the restorative or hygiene room. And so then we kind of forget when some patient come through because we weren't focusing. So you really need a system to say, I'm going to screen all of my adult patients. Okay. And then once I screen them, that we're going to identify the ones who are at high risk. Someone needs to take the time to sit down and talk to that patient who's passionate and believes that this is one of the most important things they'll do for that patient in their lives, possibly ever, as a dental provider, and get them to understand that they're at risk for choking to death at night. And then we need to orchestrate getting a test for them, and then we can get to the treat. And you need to have a system where you screen all your hygiene patients or all your new patients. Figure out who you're going to do this with. Maybe if you've got a busy office, you don't try to tackle it all the first day you're there, but you need to have a system for this, and eventually you need a system for the financial aspects of this as well as what we're going to charge the patient. At DS3, we put together a screening application to our cloud-based software. And today we were talking to one of our consulting. We do some consulting for some of our members. It's called the DS360 Premier Tier Package. We were talking to one of our members today. They may be on here, and I think they were using something different than this. And as we walk through how this system allows you to ask some questions that aren't proprietary questions, ones that Rich and I and our team put together, but it makes it easier for the patient to test. And then what they really liked is this at the end. The patient's holding this tablet in their hand that says they're at severe risk. And, what do patients do then? They're holding this thing and they're going, what's this all about?
Severe risk for what?
Right. And that's what we want, right? We want our patients to ask us questions that we'd like to answer. That's the most beautiful thing when you can get a patient. Wouldn't you like your patient to come in and go, oh, what do I do about my broken tooth? Can you fix it? Yeah, we'll put a crown on it. That's a lot easier than telling them, hey, you got a broken tooth, you need to have a crown on it. It's a subtle difference, but it's a huge difference. And so our system allows it to do it that way. You can use other systems like the Stop Bang and Epworth, different things out there. But the key is it needs to identify the patients fairly quickly, 3 to 4 minutes of time to fill out, and then someone needs to take this information and discuss the results. And if they're discussing this with the patient and 1 out of 20 is getting tested, they're at severe risk, you've got a broken chain. I think if the vast majority aren't spending a couple $100 is all it's going to cost to $200 to $300 to get tested, there's something wrong with that. And I don't want to diverge too much, Rich, but we were doing some consulting in an office a few months ago, and they were saying, well, the patients don't want to pay for this. They don't want to pay $200 to have this test. And the hygienist was telling me that. I said, well, how much did that patient just pay to come here today? Well, they had the cleaning, They had the bite wings. The doctor checked them. It was well over $200. I said, so you're telling me that a patient will pay you more money to scrape tartar off their teeth than to breathe or to possibly know that they're choking to death at night? Does that really make sense in the big scheme of things? She kind of just laughed and realized, how kind of non-forward thinking, or how wrong her way of thinking was, because she just didn't believe in it. I think is what it amounted to. So I'll shut up for a second and let you talk, Rich. Sorry about that.
No, it's lopsided, and we think about that. So part of this is what you believe in. It goes back to that slide, Guy. You said, hey, and a lot of this doesn't matter if you don't believe in it. You got to believe in this and what you're doing and how we do that. And you have to educate your staff. There are 100 questions asked at your office every month, and 90 of them are asked to your staff, not to you as the doctor. So, and don't get ahead of yourself. And don't get your hygienist behind. If your hygienist is screening people and you're using the DS3 screener, and you go, oh my gosh, Guy, look at this, man, you're severe risk for what? For sleep disordered breathing. Your jaw set back, you got a big tongue, you got high blood pressure, you snore. Man, there's an 80% chance you have sleep apnea. We need to get you tested.
Yes.
How are we going to do that? So we're putting the cart before the horse there now, but I can say that, and I can talk at least 9 out of 10 people into getting a sleep test, and you're talking about the hygienist, and she says nobody wants to do it. That's not because I'm a better salesperson. It's just because I've seen people die with this, and she hasn't yet.
That's exactly right. You believe in it, and we get them tested. By the way, we see a lot of questions coming in. We're answering those. Our DS3 team's answering. I know Rich is answering a few. We will get to all of them, so just keep them coming. We'll verbally or written answer them as we go. So once the patient says, "Oh, I get it. I may choke to death in my sleep," then we said, "Well, we need to get you tested." And you taught me this, Rich. Well, okay. Which way would you like to be tested? You want to go to sleep lab? You want to do it at home? And physicians don't give you a treatment plan for to go get a stress test if they think you're going to die of a heart attack. They just say, hey, you need to be tested. Here, you're going to go here and get tested. And we're a little bit nicer than that. We'll say you need to be tested. We'll give them a choice. You can go to the sleep lab or you can do it at home. And if you just use it just as calmly as that and say it like that, I went in that same office we're talking about, and I got 3 people in less than an hour to agree to sleep tests. They never met me before because, I believed in it, and just kind of matter of fact, you need to be tested. So they knew it, and they agreed to it. So you need to have a plan. And I have some patients, Rich, ever so often still say, I would rather go to sleep lab. I don't sleep well at home. I've got dogs and kids and cats or something like that. And occasionally they'll will that. So you do need to have a place you can send people for in-lab sleep tests. But far and away, Rich, you're working a lot with the primary cares these days, getting them tested. Are most of them getting home sleep tests?
The bottom line, Guy, is the payers don't want to pay for in-lab tests anymore. So it really doesn't matter, and I love that verbiage, would you prefer to go to a lab or at home? I think I want to go to the lab. Well, that same guy, if you go, well, your insurance doesn't pay for the lab test, but they pay for one at home, he goes, okay, I'll do it at home.
Sure.
So a lot of this depends on, what the payers pay for. So I heard you say once, Guy, a home sleep test is a slightly less accurate test of a more typical night's sleep. So the bottom line is it's good enough. Okay, it's good enough for what we want. We have to work with the physicians in order to do this, but you have to have a plan too. Remember, the physicians have failed at this. Not all of them. There are some who have done very well at this. That's not a blanket statement. But when we look at sleep apnea in general, and we've only identified, 10 or 12% of the patients that have sleep apnea, we've just not done a very good job, any of us as physicians or dentists or PAs or nurse practitioners or whatever, because they're doing, PAs and nurse practitioners, Guy, are doing an awful lot of the primary care physicianing out there in the world today. I don't know if you know that or not.
Yeah.
So, and when you do these lunch and learns and you do this, do not overlook those people. They can be a tremendous referral source. But right now, we're screening somebody and we're trying to get them tested. So don't use big words. You don't put the cart before the horse. All the things that we've talked about up to this point. Figure out how you're going to do this in your practice, and you have a couple of ways. Some of you have bought your own home sleep testing equipment. That's okay. We'll help teach you how to use it. Can you use it? Yes, you can. As a dentist, you cannot make a diagnosis. We're not supporting that. This is, what is this, Guy? May of 2019.
Right.
As we say that, we know these things get recorded, and we're already seeing some of our recordings that are out of date, because things change, and things will definitely change in this area. But you can upload that to a cloud then, and then you can have a board-certified sleep physician actually make a diagnosis. So you can work with a home sleep company who works in your community. There are national companies that do this as well. It requires no outlay of capital of any part. And lastly, you can work, with a physician who either does that either in his own lab or he has home sleep testing as well. These are all options, and they can all work. You just have to figure out which one works best in your hands and in your community and with the group of physicians that you work with.
Yeah, and even in individual patients, because I do all three of these in my practice. We utilize all three of these at any given time. And as Rich said, these things are changing, but the ADA has a position on this now, and we feel that all three of these have their place. One thing I want to make clear is we don't recommend that you go from this sleep test with a diagnosis and go treat the patient without talking to the primary care first. We think the primary care should be involved, let them know what we're doing, ideally get some letter of medical necessity and a prescription, a written order from them after we've gotten the diagnosis, or maybe they're the ones that helped us with the diagnosis in example 3. But I don't want anybody to leave here thinking that thinking we should do this completely without involving the patients, the physicians that are working with daily and weekly or yearly. We'll talk about communication in a little bit and how we do that. If you're a DS3 member, we make that middle option really easy. We work with 2 companies, sleeptest.com and Blackstone currently, that you can order a sleep test through, and you click the button, and it just takes a lot of the faxing of the paperwork. The data comes back into DS3, and just makes your life a whole lot easier to deal with, and a little less paperwork and faxing back and forth. So moving on, we're going to talk about treating the patients. You really need to find a system to manage all of this information. It wasn't like Rich and I sat down and said, I've got nothing better to do in my life. Let's suck up 80 hours a week for the next 10 years and build a cloud-based software because there's no need for it. There was a huge need for it. We couldn't be productive the way we were, even with some of the other systems that were out there. So we developed a cloud-based software called DS3 that in combination with our training helps make all this processes much more smooth. You can do it without DS3. You're doing it in under an hour of doctor time might be very challenging. That's what we teach you how to do. Again, if you want to know more about that, just feel free to type in consult or consultation. We can answer all your questions. We're not high pressure people. I don't want you to feel like you're going to be pressured. It'll be a genuine conversation about where you are in dental sleep. You're going to get a lot of information out of it. So type that in, and one of our trainers will get back with you. I like this slide, Rich, because it kind of talks about the way we do things. And when we get finished, we'll talk about the way CPAP does. And I like to start out when I teach people in the courses, go, what do you want out of this? If you're going to wear a piece of acrylic in your mouth or CPAP, what are we trying to do? Well, we're trying to help your symptoms, and we're probably trying to live longer, to be healthier. And so in dental sleep, we have those 2 goals, but we start with the first one, which is kind of the last one in CPAP. You got to wear the device. So every patient that I talk to say, you know what, we're going to give you this piece of acrylic, and we're not going to talk about anything else but compliance. When you come in, if you're still snoring, we'll get to that later. How well is it working with the AHI and everything? We'll get to that later. Because if you're not wearing it, it doesn't matter. Then we talk to them about their symptoms, and we'll show you how we walk through the symptoms with a system that I think that's one of the things that we did really well, Rich, is we objectified a subjective process, which makes that easier. And then when we're finished, we do a follow-up sleep test to see objective success. So we go in this order. And I honestly believe dental devices overall certainly work as well as CPAP, and in my bias is maybe better. And I think it's because we do it in this order. How does CPAP work? They take your CPAP, they crank it up until your AHI is better, and then they go, okay, we've got objective success. We hope you feel better. We hope you wear it. They go the exact opposite, and I think that's the downfall. I think we start on the top and go the other direction. If patients start wearing this and then they start feeling better, they're going to be a long time treated, and then we can tweak the objective success as we're going to show you here in these next few slides. So.
That's good. That's a good way to look at it. You know, we just CPAP and dental devices come at this from opposite ends of the spectrum. So this kind of gives you an idea. What we're doing here is we're kind of walking you through these steps. So we've screened a patient and we have figured out a way to get them sleep tested. You know what my favorite sleep test is, Guy? The one that gets done. It's the one that the patient will do. I don't care what kind you get. I just want you to get the sleep test done. And, you know, now we're finally getting to the part where we're actually, you know, we're going to do a consultation, and then we're going to walk through these steps now. But as you can see, we've had to do a fair bit of work already. You know, a lot of this is front end loaded. That's the way we like to say it in my office, you know, where we're doing a lot of this work before we get paid. But that's okay, because it's very meaningful work and we like what we're doing.
Yeah, so we'll go through these steps. The consultation, you know, we're not perfect in my office. I had a patient in Monday and I went to my chart and everything wasn't there that I needed. And I'm going to talk about those three things in a minute. I think we beat this up enough, but your patients will trust you when you're prepared and you believe in what you're doing. I don't think I have this slide in here, but people don't buy what you sell, they buy what you believe. As a saying that I ran across the other day. And if you believe this is valuable and you believe you can do a good job and you know you're prepared, the patients are going to say yes to treatment. The three things that I want to have before a patient sees me is their sleep test, a questionnaire showing what their symptoms are, what their concerns with snoring and sleepiness, how many times they wake up. We're going to walk through these fairly quickly. And then from that information, we talk to the patient about, you taught me this, Rich, what do you want out of this? What's the number one thing you want? And they'd write that down. Well, what's the number two? And it might be, I want to snore less so my wife can sleep in the bedroom with me. Or I just had a heart attack and I don't want to have another one. That's the number one thing. And we write those things down in 1, 2, 3 order to as many as there are. And then we tell the patients, well, here are the odds of us achieving that. And I think you're a good candidate. And they're sitting on the edge of the chair going, well, how much is it? And I have an answer to that one too. You know, so if we have these three things.
Sounds good. It sounds good. How much does it cost?
Yeah, I mean, if we do a good job, that's when they, you know, they're like, please, well, this, yes, I want one. Can I have it? You know, and that's a whole nother subject. Dentists get nervous when patients ask how much something is. And that's really, they've not thought about this well. Most salespeople want you to ask how much something is because that means you want it, right? That's the buy-in side. And so when a patient says how much it is, it shouldn't stress the dentist or the team out. You should be excited that they ask, and you should have an answer. And if I have these three things in order before the patient ever comes in, we can do a consult in just a few minutes of my time. I was in your office, Rich. I don't think you spent more than 10 minutes in a consult, the bunch that I watched you do, because you had this information in order. And, you know, we spent a lot of time arguing over this, didn't we? What are we going to pull out of the sleep test? Remember how long it was at one time?
I will like to say we were both wrong.
Yeah.
We used to have about 500 things we wanted in there, and we seem to, you know, distill it down. Let's get shorter and shorter every year, but this is what we want. You know, we want a sleep study that's not more than a couple of years old. Is that written in stone? No, that's not written in stone. It may be with the payer. That may be something that you want your third-party biller to ask. You know, how new is that? Is it at home? Was it in the lab? What were they diagnosed with? That's a very important question, because most payers won't pay for this unless there is a diagnosis. You know, occasionally, guys, somebody will still sneak through in my practice and they'll have a diagnosis of primary snoring. They weren't diagnosed with sleep apnea. That's okay. That does not mean that they don't need to be treated. You can have very symptomatic patients who have an AHI of 2.3, and they need to be treated, and you can make a tremendous difference in their life. But we're just looking at HI, RDI, and then on their back, and then how low their oxygen goes and how long it goes below 90. So we have distilled this down, and we think that you need most of this at a minimum when you review the sleep test. And when we go over this with Guy, has anybody ever explained what these numbers mean to you? That's how I ask it. And what do most people say?
No, they have no idea. I mean, a friend of mine that's son plays with our son on soccer came in, and I've taught them, you need to get in. He's not wearing a CPAP. Really severe apnea. He didn't even know how bad his apnea was. He's going down to the low 70s, quitting 50 times an hour with the AHI, and no one even went over that with him. And it happens every time, and they're going to be very appreciative that you did. And what we've done here is distill this down. At a glance, you can see what's going on with the patients. We have a full copy of the test where we can view it, and our team will pull this out information for us after we train them how to do that. If you don't know how to do that, we'll train you how to do that. And then if you order tests through DS3, it automatically comes in looking like this. So it saves us that information. But at a glance, we can tell this patient has pretty severe apnea, and how old the test is and what their diagnosis. So in 10 seconds, we can know what we need to know about that patient. Well, we want to do the same thing for the patient's questionnaire. We want to know their complaints and symptoms, what else they've tried, and their health history. And they do this through the web portal before the patients come in. So we send them an email, it texts their phone with a password. If they don't have a text, we can give them a password. If they don't do email, we'll mail them a questionnaire, and then we have to type it in by hand. But most patients will do it online, and then we get all this information that you're seeing here: their sleepiness, their snoring, how their sleep quality is, how many times it wakes per night, witness apneas. And once all that's inputted into the cloud portal from their home, we get a notice, and we just click accept the input. And at a glance, we can see what these patients look like. We can see their health history. It's a little small on the screen here. I think the next slide shows a little better. We can see at a glance what someone's sleepiness scores are, snoring levels. If these numbers don't mean anything, if you don't know what an Epworth is, then we need to, this is kind of a high level overview. We certainly can teach you what some of these terms are if they're not familiar with you. It's pretty simple in some of the courses that we can teach. But at a glance, I can tell Rich, this person's sleepy and they snore and they have low energy. And I know some of the questionnaires we looked at, they were 15 pages long maybe? Some of them. Remember the one I remember one of them in particular was close to 15 pages long that we looked at, and we argued over what we want to include. And it was, even our first rendition of this was probably 3 or 4 times longer than this. Wouldn't you agree?
Yeah, and I think what have we learned, over the years, Guy, in doing this? It has to be simple.
Right.
And it really does. We cannot overemphasize this. And if you are one of those dentists whose life is very complicated and you can't make a decision with anything you do, you better hire really good staff, because you're in for trouble if you go down that road. You have to keep this simple. And the more simple you can keep it, the more efficient, the more productive, the more people you get to help, the more people say yes to treatment, the more you get paid. I mean, I can't think of one bad thing that comes from any of that stuff. It's all good, no matter, what your motivation is. Our motivation has always been to help dentists treat their patients better. That's why Guy and I are here tonight, taking time away from our families and doing this for you guys, because we believe that. And we're starting to move the needle now across the entire country, because there are more of you dentists out there who are getting this, who are starting to get on board and doing this. We make money, when you guys buy into our system, and we help teach you how to do that. But you got to keep it simple.
Yeah, and I think that's what I'm most proud of that we've been able to do, is to make it looks simple when you look at it now, but it wasn't. To make something complex as simple as possible, I think that's what we specialize in. And remember, the 3 things we wanted were the sleep test, the questionnaire, and then how much is it? Well, it doesn't get any easier than this. We have an instant eligibility check that's in DS3, and there's ways of doing this manually by calling on the phone and spending 30 minutes on the phone to find this information out. But at a click of a button, we can find out if this device is covered. If so, what deductibles are left for both in and out of network, and what are the copays, 70-30, 60-40, that kind of thing. And with that information, if you'll attend one of our billing webinars or in-person courses, we can teach you how to take that information and give the patient the answer to the wonderful question, how much does it cost? We'll be able to answer that very readily with access to this information. So we've got all that together. Again, the sleep test, the questionnaire, and the financial situation figured out. All three of those need to be done before the patient ever comes to my office. And then I can walk in for a consultation. And if my team goes in first and goes through all this stuff on the screen, I can spend 2-3 minutes in there. If I want to do this myself, maybe I'll spend 10 minutes. But, I think the key here is to do what Rich said. Explain to them, go through their test. Talk to them about apnea. Talk to them about their options. And then this established goals, I don't think we can overemphasize how important that is. What do you want from this? 1, 2, 3, both subjective and objective. And how are we going to follow up testing? I don't know about you, Rich, but you work with a lot of primary cares. We ask every doctor that we work with, how would you like us to follow up with the testing? You want us to do it? You want to do it? Do you want us to use one of these third parties? And we try to adhere to what our referral source desires are. That way they'll be happy to refer some more people. So that follow-up sleep testing really depends on where the patient came from, at least in our office.
I think that's smart. Don't cut off the hand that feeds you. If you have a doctor that wants to refer you patients and he does home sleep testing in his office, then by gosh, send him back and let him do it. But I think more than anything, Guy, what you said there is have that conversation.
Right.
Just pick up the phone and call. Go, hey, maybe talk to the nurse or the referral coordinator and say, hey, this is Guy Yotis. So, how do you guys want to do this? I hear things, Guy, from if I ever hear of you doing a home sleep test, I will never refer you a patient again. I hear that, and 2 hours later, I hear a guy say, thank God somebody's willing to help me do something. Yeah. Yes, please do the home sleep test. I don't have
to do it. Thank you. It's all on you.
Yes. Right. I think that's a more normal response, by the way. Right. But, again.
I have one guy that wants everybody to go in for a PSG still.
There you go.
So we tell the patient.
That's pretty much, the high, low, and the middle there. So, right. but you got to know. But remember, when you're doing this consultation, don't think like a dentist. Dentists think in tenths and hundredths of a millimeter. In medicine, you have to back up and you have to look at the big picture. What's going on? How can I help you? How did all this get started? My dog kicked me out of bed because I was snoring so bad, or, I have headaches in the morning. It's just, how did this happen? You got tested. You understand the test. What can we address? What's reasonable? What can't we? Hey, let's look at your jaw and can you move your jaw? Are you a candidate for this or not? And let's get things going.
Absolutely. So then we're going to do an exam, and that exam, we could spend 30 minutes on it. But I can honestly tell you, I don't spend more than 5 or 6 minutes doing most of the exams. We're going to look at the teeth to make sure they're strong enough to hold this. We're going to look at the soft tissues to document what's causing the airway problem, at least from what we can see it. So we look at things like the tonsils, the soft palate, the hard palate, shape of the arches, sizes of the teeth, whether they have obstructive tonsils or not. I think we went over the nose there, whether you can breathe through your nose or not. It's really critical. Rich and I could spend an hour just talking about that probably, but evaluating their muscles, their range of motion, how much they can move their jaw, any TMJ problems. But we have a system where you just walk through that. And I know when I was in your office, Rich, you're spending less time than I am, and I'm spending 6-7 minutes on this and feel like I'm doing a good job on that. And then we take impressions or scans. Rich and I both, you got the Carestream 3600 too, I believe, right? Love that machine. We've had it for 3 or 4 months. Man, it's really making our devices fit better. We're not putting the videos coming out in Dental Sleep Medicine Insider. I'm showing you how I do it without bite registration material. We're using those. You can look at the scans too to see the shapes of the teeth. That can help us with the device selection and then we decide which device is best on that patient based on, first of all, their insurance. If they're Medicare, that could affect it. Their teeth, bruxism, a lot of things like that. We have a whole hour webinar on which ones you select. So we'll be doing that one again in the future. So stay tuned for that. But at the end of the day, we're going to pick which device we think is best suited. But Rich, I'll let you say what you say about devices. Don't stress about this because what you taught me, do you remember? You can't.
I do. You can't pick a wrong one, but you can pick a better one.
There you go.
So don't stress over it. Just pick one. If you're new at this, just close your eyes and throw a dart at the wall, and whichever one it hits, pick that one. You're better off, doing this. So, the next thing we're going to do is deliver the device. So I think, Guy, you taught me this a long time ago. You said, you've worn a night guard before, and what's a little bit different about this is it's going to feel a little more tight. It's got to grab a hold of your jaw, and it's got to move your jaw forward and hold it there, and it's got to be able to withstand the weight of your jaw opening. And, I had a guy the other day, and his head weighed 100 pounds, Guy. I swear the guy weighed 675 pounds, and I held his head in my hand. I was like, my God, your head weighs 120 pounds, Well, that guy's device needs to be tighter, than the 4'3" little old 92-year-old lady that walks in. If you make it that tight, you can't get it out. So, but inform them, show them how to put it in, take it out. We're going to make an AM aligner. Everybody gets an AM aligner. That's not an option to do that. We show them how to do it. We have little videos, Guy. We sit them down to watch a 5-minute video. That's the first thing they do. And in my video, I say, hey, I'm glad you're here. We're excited to get you started with your dental sleep device. The first thing I want you to do is relax, because you're not going to remember everything we tell you today. So the only thing you have to remember is to put it in at night and take it out in the morning. That's it.
And the trick, I'm big on efficiency, so my team does all this. And then they put it in the patient's mouth, and they come get me with it in the patient's mouth. Why do I do it that way, Rich? Do you know? Because the patient can't talk to me when I come in the room. It saves time. So I got this in their mouth. No, that's part of it. But honestly, then I do take it out and ask them, I check with the fit, see if they have any questions. But in Florida with the older patients, if they've only put it in 2 or 3 times and it's sitting on the counter, I may watch them for 7-8 minutes, struggling for the 3rd time to put it in. It can really save time. So my team puts it in, or they walk it in the room with it in their mouth, check everything, bless it, whatever you want to call it, and make sure it looks good, and then we're on the way. So it takes very little of my time. So they're going to come back. We're going to have you come back about 3 weeks later, because after about 3 weeks, the patient's really gotten used to this. Rich and I, we won't argue about it now, but at one time we did. And Rich we were doing it 1 week. And what we learned is about 3 weeks later, a lot of those little problems are worked out, whether their tooth's a little sore. And we're going to ask them if they're wearing their device. And if not, we'll say you should have called us, because our agreement is if you're not wearing it in these 3 weeks, you come in. And so I'm going to say, hey, we had a miscommunication because you were supposed to come in if you didn't wear it. And if not, why aren't they wearing it? We adjust it, too tight, too loose, grind on it. You can figure that out as dentists. I don't want to take too much of your time with that. If they are wearing it, then we're going to ask them if it's working. And if the answer is no, we're going to move that device more forward. In particular, most cases, we're going to train the patient on moving the device more forward, give them specific instructions, and then we're going to ask them again in the future, is it working? And if the answer is no, we'll play this little game for a little while. And then once they say yes, then we'll do a follow-up sleep test. So we're going to show you how that kind of works clinically. This patient comes in and they're sleepy, snoring, energy levels are low. They've been wearing it 3 weeks. They're comfortably wearing it. We ask them the same questions. What do you see there, Rich, at a glance?
Sleepiness went from 19 to 8. That's fantastic. The snoring went down significantly. Their energy level's up. Their sleep quality's up. You're not waking up as much at night, and your bed partner's not seeing you choke on your big fat tongue. So I would say, we're definitely moving in the right direction. That's how easy we make this. You just look at this, and again, the staff is going through this, and they're answering these questions and putting this stuff in there, and then you walk in and decide what's going to happen next.
A lot of this, the team can do it without our supervision, because ultimately we're going to check the sleep test. So, I mean, if they want to walk through this, I don't see any problem, at least in the state of Florida, with them talking to them about tweaking their device without my input. And so let's say it wasn't here. Let's say that their Epworth went down to 12 and the snoring, was all just a little better. you go back to your chief complaints, 1, 2, 3, and if their chief complaints were sleepiness and snoring, I would say, well, looks like we've improved your sleepiness and snoring. Are we where we want to be? That's what I usually say. And they'll, at that point, we'd probably say, not exactly, but ask them, are we where we want to be? And once they're there where they want to be with those, we're done with this particular part. If we weren't, we would have them adjust the device a quarter or half a millimeter each week for a few weeks. We'd have them come back in, or in our office, we just call them. If they don't want to drive across town, we'll call them and we'll go over those symptoms again with them and put another column in DS3. Now, ultimately, the patient's going to get to the point where they're, I don't know, Rich, I throw a number out when I teach this. I would say 19 out of 20 times we get the symptoms to where the patient is happy with it. The majority of the time. I don't know if it's certainly not 100, but it's well in the high range that we usually get to a point where the patient's fairly happy with their symptoms. Would you agree with that?
Yes. And it also depends on where they came from. Somebody who used CPAP and was miserable with it and hated it and took it out in the backyard and poured gas on it and lit it on fire, they didn't just give it back. They had to burn it first. Those people, and if they're very sleepy and they're very tired and they're very motivated. So again, everybody's different, but one of the hardest things we do is to try to figure out, what that device position needs to be. We could talk about that for a couple hours. So I will tell you, don't stress over it too much. Just do the subjective tests like we're talking about. Like Guy said, we're trying to objectify something that's subjective. I'm going to have to quote you on that. That's one of my Guyisms, I call them, when Guy says something like that. So, but that's really what we're trying to do. Don't stress over it. After you do a couple hundred, in your mind, you're going to kind of have a feel for when these people are doing better. And until then, just put some numbers behind it. Make it as objective as you can. And, again, we're just trying to figure out. And we've tried to put little slots here where you can do this. You can see all this. Next, we're going to get them sleep tested. Now we're finally going to get them sleep tested. Now we can do a 3-night home sleep test, and we can test them at different positions. And then we can see if they improve or not. My staff puts all of this stuff in here. I just pull it up and I go, holy cow, okay, let's see. It looks like the +5 was the best position.
Yep.
That's not real hard, is it, Guy?
No, we could talk to you more about what you look for there, more than just AHI. You look at the SpO2 readings, but the bottom line is this was the baseline. Here's 3 positions, and all we have to do is make a decision. And once you've done a few dozen of these, and if you've taken some of our courses, we can train you on making this decision in a half a second with looking at the information that's here. So that's why I don't mind having my team subjectively go over that information, because ultimately I, as the doctor, am going to make the final treatment decision based on this objective data. So it's a really good system. It works well. We're going to see our patients after this. Sometimes I see them at 6 months. If they still have some titrating to do, they have any complications or any reason, I'll see them at 6 months. Sometimes the milder cases we go a year, but at the very least, we want to see our patients once a year, because apnea gets worse with time. It's a progressive disorder. Some studies show it gets as much as 20% worse every 5 years. So these patients need to come in every year. It's for us to evaluate them, or at least we need to recall them, and hopefully they'll come in. One critical thing, and as we're winding down here, because we got to talk about this in medical billing over the next few minutes, is you are now the specialist when you do this. We can't call ourselves a specialist, but in a sense we are. And if you work with a periodontist, oral surgeon, orthodontist, and you never get any communication from them, would you want to continue to work with them? You think about all the letters you get from them. Rich, I thought you were lying last year when you told me you did like 6,700 letters or something. I went in the DS3 software, and it was well over 6,000. I think it was like 7,000 letters or something. I have to pull it up again that you sent last year. We have a system where you do it through the digital cloud. Basically, the DS3 pulls up all this data, and you just hit a button, and you don't have to put a stamp on it. You have to put it in a fax machine. It costs you nothing to hit the button and send it. We have templates to send these letters to make it really simple. But I wonder how much that would have cost you and how much time that would have taken had you done that in a Word program. I put the math to that, I wonder.
I hate to do that, Guy. I don't have much spare time now, and it is true. And we've just tried to help you do this. I mean, I know some of you are out there and nobody wants to buy another software and learn it. We've tried to make it as simple as we can. And I'm just telling you, if you want to practice this at a very high level and be very efficient, we have a system that helps you do that. And you have professionals and member support experts and people that can help answer all of your questions. But you have to communicate with these physicians. I think that's the bottom line. I mean,
yeah, whether you use our system or not, to just do this and not send letters is not acceptable. You have to do it. It's our job, or you're not going to be doing a complete job.
And all of my letters are short, 3 and 4 sentences at most. They're very simple. Is the patient, did they show up? Are they wearing their device? Are they doing better or not? Are they ready for a follow-up sleep test? That's all the physicians want to know. I've seen dentists write 14-page, soap notes about, and I hear physicians every day, Guy. I get to do this every single day, and physicians say, look, don't tell me stuff I already know.
Right.
I'm the one that made all those diagnoses. I already know all that stuff. I send them to you to treat their airway. Are you treating their airway or not? That's all I want to know.
Right.
So, that's why we try to keep it simple. But at the same time, I'm constantly staying in front of these physicians. A couple of questions we had, Guy, were, well, hey, if, Dr. Drake and Dr. Yatros aren't doing general dentistry, how do they get patients? Well, that's a good segue for the next one, is tune in, because, that's what we're going to talk about with the physician referrals. But a big part of that, not to let the cat out of the bag, is doing letters. And this, you see the screenshot here that Guy took, we have all of these templates built in there. And what that does is it pulls information from other places in the software. Hey, they had a sleep study. This is what their AHI was, this and that. So it makes your job of doing those letters a whole lot easier.
Yeah, and like Rich said, they're all one page. They all digitally fax through the cloud, so that you don't even have to put it on paper, and that's how we do it very efficiently. When it comes to billing, we taught a whole day course, and the symposium last year on billing. It's medical billing, not dental billing. It's totally different. You're literally crossing a line in the sand to doing medical billing when you do this. Our quick answer to this is you work with a third-party biller. There's a lot of them out there. Our company has a subsidiary we work with. We work with some other ones in the industry that all we do is bill for dental offices for dental sleep. And it's a whole nother subject. We will be doing a webinar on billing, but if we get too far in the weeds on billing on this one, they'll take up the whole hour and then some. I think I'll end the billing on, it's doable, it's profitable. You just need some help to do it, and you need systems set up in your practice, and we can certainly help you with that. Until you get those, then do a fee for service, do some treatments on your friends and family at a discount till you get going. Don't let the billing stop you from getting going. Get started tomorrow doing some of the stuff, and then you can add the billing in as you want to expand. So there's a lot of decisions you got to make in the billing. So here's the steps we went through. Look at this, 903, not too bad that we kind of got here. I promise you, if you utilize the DS3 system, if you utilize our training, you want to know more about it, just type in consult or consultation, and someone will meet with you and talk about your challenges, give you some good free advice, and see how we can get you doing this in well under an hour of your dentist time and helping your patients be successful, because nothing you can do has a higher profit margin than dental sleep, because so much of this can be done by team members. I've looked back at this, Rich, and there's nothing I did in my practice that was per hour of my time more profitable than this, because my time when I did a crown prep was at least half of my time. And with this, you can delegate it to team members. And there's a higher need. There's more people that need this than need crown preps and implants and a lot of the things you do as dentistry. And even if you just did one a week of these, just one a week, which you almost have to be not trying, and you paid for our services, you pay a third-party biller, and you got $2,500, you paid your lab fee, you're pushing 6 figures adding to your dental practice just from one a week. And a lot of practices do one a day if you just start screening your patients. So hope that the finances is not the only reason you do this, but if that's one of your motivating factors, it really has one of the best potentials of anything in dentistry today.
Yeah, I heard Gordon Christensen say the other day, Guy, that sleep will be the savior of dentistry.
Oh, wow,
So,
really?
yeah, you know, people are needing less dental work. It's something that we can transition into and be good at. Get ahead of the curve. You know, if you come to San Antonio and you want to do this, I would encourage you, but I got a 20-year head start on you. Well, at some point, you know, it's going to be 20 years from today. So those of you who are looking to transition out of a restorative practice, you can do sleep medicine. I mean, you know, Guy is the efficient king at all of this. He used to teach me, you know how long it takes me to adjust that device? Hey, Ashley, will you adjust that for me? There you go. That's how long it took me. So, you know, you can see a lot of patients and you can be good at this because we get to use our brain more. We don't have to use our hands quite as much. I think that's what I like about it, Guy, because I've had surgery on both my hands and elbows and all that other stuff. So I have a hard time, you know, doing general dentistry, but I love getting to use my brain. So I'm really excited about the next one, Guy. You know, that's my passion, is getting out there and doing that. And I don't know of anybody in the country who does as much of this as I do. I work hard at this. You know, and I get out there and work it. I have a full-time marketing person in my practice, and her only job is to get me in front of physicians and PAs and nurse practitioners. And she does a great job at it. And we're going to talk about all of the things that entails next time and how you can start doing that and being more successful at this.
Well, that's going to be fantastic. I'm looking forward to that to myself. If you want to know more about how we can help you, we have a 360-degree solution for you. I think a lot of people that kind of know a little bit about us think we're just a software company. I do agree we have the best cloud-based dental sleep software out there by far. We're always improving it. It's even getting better as we speak. But that's not all we are. We have the systems, the training, support, a whole team full of dental sleep medicine experts that can help you. And if you're new to this, then we can help you from learning how to do this with you and your teams. If you're not new to this, we can help you by learning how to do this more efficiently. This Dental Sleep Medicine Insider is free, so if you're not subscribed, go ahead and go to the website you see here. The new versions, the new editions coming out here shortly. I saw your article, Rich. That was really good. I did one on using a digital scanner and how you take the 3D bite with a video that it is pretty short and sweet, but I think worthwhile. We're well over 30 issues of this now, and Jason Tierney, our COO, really does a phenomenal job on this. He's a great editor and comes up with great ideas. A lot of great contributors to this. So look for that. There's our contact information. Rich, you've been looking at some of the questions. Where are we at on those? And let's make sure we get them all.
I think we're pretty good. Our team has done a fantastic job, you know, of answering all of these. Can a practice exist on dental sleep medicine alone? Well, I would challenge you, Dr. Kyle Ash, to come to my office and you tell me. Okay, you spend a day with me and you say, "Holy cow, man!" Yes, you can. Absolutely, you can. I think that's good, Guy. Our team has done a fantastic job of doing that. Thank you, and Jason, for putting together a fantastic PowerPoint as always. And thank all of you guys for spending some time with us. You will be getting your CE through your email. Be sure and check your spam folders if you don't see it in your regular inbox. And anything else, Guy? We'll hope to see you guys next June 11th.
Yeah, and be on there for that. If anybody, again, wants any of the discounts on the course, we'll leave us on for just a second, type course or consult. Other than that, next month, Rich, I'll put something together, but I'll get it to you because I'll write a template for you and let you put all your magic secret sauce into this one. I'm excited to do that one with you in a few weeks. Anybody coming to the AADSM, we hope to see you there. We'll have a booth.
Yeah, please come by and say hi to us. It makes Guy and I feel really important when you come by and you say, "Hey, I know you. You're that bald-headed guy on the webinar, you know." And
certainly come by. Don't be shy. Say hello. Introduce yourself. We'll be more than happy to talk to you. Got questions, what have you. Rich and I will both be there for the whole thing, and look forward to maybe seeing some of you at that meeting or meeting in the future. Thanks, Rich. Thanks, Jason, Tierney, for all you've done to make these meetings happen, and our whole team, Jody, Mike, and Brandy, and Kelly. So, and Lisa from our 4-pillar billing. I don't want to forget anybody. Makes all these meetings happen, and we'll see you in a few weeks on medical billing. Good night, Rich.
Night, guys. Have a good evening.